All right. So good morning, good afternoon, good evening to you all, wherever you are in the world watching this. My name is Kapil Nayar. And before I begin, I just want to take a moment and thank or express my gratitude rather for the NBCC offering me this opportunity to speak to you all for the Bridging of the Gap Symposium. This is a topic that's near and dear to my heart. I have firsthand lived experience through some of the things that I'm going to be talking about today. So I just want to preface and say thank you, and also preface and kind of warn you all about my inherent bias. I am fully aware that most of this information people are kind of mindful of and aware of, but for some reason we're not talking about it. So I just wanted to take this opportunity, express my gratitude, and also let you know that this is probably going to be a little bit biased. But I'm hoping that this provides some psychoeducation and offers some sort of groundwork for us to be able to continue having this sort of dialogue. A little bit about myself. My name is Kapil Nayar. I'm a licensed professional counselor. I'm licensed in New Jersey, Pennsylvania, Arizona, Minnesota, and pending in Georgia. Much of my time has been spent working in substance use disorder treatment. I went to school in Philadelphia at a school called LaSalle University. After graduating there, I worked in a nonprofit. It was a traditional inpatient program in Southern New Jersey. And from there, I went on and worked for the for-profit sector and a Florida model of care. And then from there, I kind of transitioned into private practice. And then further on, I currently work at one of the largest health insurers in the country. So I've seen a few things, and kind of through my time, I have compiled enough evidence to be able to present on this specific topic. I'm currently working on a PhD, and my dissertation is also going to be on this topic. So I'm pretty excited to be able to share this information with you all. And again, hopefully this gives sort of a roadmap as to how to go about navigating if we are to see something. So to begin this conversation, I thought it would be significant to start with a conversation on three specific acts that were rolled out by congressional folks. And this has a lot to do with open enrollment. And so hopefully in this next series of slides, we'll be able to have a better understanding of open enrollment and these three specific acts and their interplay with regards to how open enrollment kind of works and functions. So to begin this conversation, I would like to start with Mental Health Parity and Addiction Equity Act. Now, this was an act that was rolled out by congressional folks that were sitting on the board, in addition to lobbyists. And this specific information was set forth to be able to sort of have an equal paradigm or equity with regards to coverage for specific levels of care. Now, before this act was kind of rolled out, mental health and substance use disorders was not really seen on the same paradigm as, say, a medical condition with regards to acuity. And so what we saw time and time again, hopefully folks listening to this would be able to attest, when I worked in nonprofit or for-profit, typically when we would have to do our utilization reviews with health insurers, more often than not, we'd have to get into this kind of awkward debate with regards to petitioning for time for care for our clients. Now, prior to the Mental Health Parity Act, more often than not, insurers would basically deny care or coverage for an extended period of time, regardless of the client's need. And so again, lobbyist involvement, congressional folks, they came up with this specific act to sort of equal the playing ground so that, you know, when we would petition for time for our clients, we would then be able to cite this specific act and sort of allow for the debate to go in our favor. So then individuals that were in need of substance use disorder or mental health care were able to push forward and actually receive the care that they deserved, rightfully or unjustly, regardless of the case. So this is a very interesting act, and it has interplay with a few other acts that we're going to be speaking about moving forward. And as we progress in this conversation, when we start talking about substance use disorder treatment, I'm going to try and reflect on the Parity Act, the Affordable Care Act, and also Obamacare or open enrollment. And also with that said, I should add the caveat of I'm going to stray away from being political here. So not to downplay any party specifically, but I do want to highlight the fact that congressional folks that were part of these specific acts in conjunction with lobbyists were privy to some sort of information to be able to roll these acts out and then capitalize on it later. I'm not going to discuss that too much in detail here, but my dissertation will definitely prove that. So the Affordable Care Act is a comprehensive healthcare reform law that was kind of enacted to give, if you will, a baseline with regards to health insurance coverage, healthcare costs, and also allow for preventative care. Now, this specific act is highly nuanced, it's pretty complex. I kind of filtered it out to give the basic understanding so that we can have this conversation as it relates to substance use disorders. But I do feel like this specific act is very important to be mindful of, as it allows for baseline or equity when it comes to seeking mental health or substance use disorder care. This specific act, in conjunction with parity, is what insurers are basically looking off of when they go for authorizing a specific level of care. And these two acts in conjunction are things that, you know, most facilities, especially the Florida model of care, are citing off of to ensure that their clients that are admitting are getting the quality care that they deserve, rightfully or unjustly. The last thing I want to talk about is open enrollment. Now, open enrollment is kind of this new phenomenon, and it's initially said to be a very humanitarian effort. And Obama and Obamacare were pretty much the tenets of allowing for this to pretty much happen. And I'm just highlighting again specific points to be mindful of. So when it comes to insurance, most folks that are awarded insurance through their employer or through their parents' employment, they don't have out-of-network benefits. And most of these for-profit sector treatment facilities, they typically use out-of-network benefits as their baseline for awarding care and authorizing care, and also for their billing practices. So knowing that, open enrollment sort of allows for folks to opt in to specific commercial PPO private plans that do have maximum amount of out-of-network benefits. And I'll speak on this more so specifically when we start looking at substance use disorders and levels of care. But if an individual is seeking care, on the 15th of the month, they would be able to opt into this specific type of plan that's accepted by a receiving facility. And again, I call this the God forbid moment, but looking at this in hindsight with regards to just medical conditions, I call this kind of the God forbid moment. So God forbid if a situation occurs where I need surgery on a vital organ, for example, my current insurance through my employer may not be able to cover this specific surgery. Therefore, God forbid, I'd be able to opt into a specific policy on the 15th of the month to be able to offset the overhead, meaning specifically, if I used my current insurance for a medical procedure that was out of network and or not covered by my insurance, my overhead costs would probably be in the ballpark of $50,000 to $60,000. And so with open enrollment and Obamacare, the initial idea was to cover for that God forbid moment. So I'd be able to opt into a private commercial PPO policy, for example, that would have coverage for this medical procedure to offset that $50,000 or $60,000 premium and kind of reduce it to maybe like a $5,000 to $10,000 premium. And so the culmination of this idea was basically, if that God forbid moment were to occur, we wouldn't have to deal with a medical condition alongside of potential bankruptcy. And so that was the original impetus of Obamacare and open enrollment. And the folks, again, that were sitting on the board when this was being rolled out were privy to this information, and they kind of used this in conjunction with the Affordable Care Act and parity to be able to manipulate a system of loopholes. And I'll speak on that as we move forward as well. So that's a general synopsis of where open enrollment kind of comes from and what is being used when it comes to authorizing specific levels of care when it comes to substance use disorders and mental health disorders. Now, forgive me in advance, I'm going to go into the levels of deception here. There's no clear-cut way to kind of start describing the levels of deception that kind of happen with substance use disorder treatment. And this is all information that we're all kind of privy to. It's just for some reason, there's no open dialogue happening about it. And so I tried to organize this in the best way that I possibly could. It is still convoluted and it's kind of long-winded, and it's also multifaceted. So bear with me here, we're still going to try. So with the levels of deception, media has done a pretty good job of covering what brokering kind of is. I'm going to start talking a little bit about the nuances with regards to brokering, an addendum to that, kind of looking at the overlap between brokering and also marketing, and discuss kind of the nuances between the two, how they're very similar and they overlap, and a few striking differences. So before brokering came to fruition and became like had any limelight, for example, when an individual was in need of care, there was an initial organic nature of being referred to a specific treatment provider. So individuals in need of care, God forbid, were receiving DUIs or being pulled over, or they voluntarily went to their PCP or their psychiatrist, and that's where the referral kind of took place. Otherwise, if they got a DUI, the emergency room pretty much provided the referral. So there was some sort of organic nature to how an individual was admitted to a specific substance use disorder treatment facility. So that initial organic nature kind of got meddled with along the way, kind of in parallel with the epidemic taking off the way it did. And there was this sort of money making scheme that's sort of happening. And so these individuals that exist in this grayscale, not necessarily affiliated with a facility, not necessarily not affiliated with the facility, took this as an opportunity to start making some money. So folks were basically chaperoning individuals in need of care to specific facilities, all the while knowing that they were going to be receiving what's known as a kickback, so a monetary gain for sending a specific individual to a specific facility. The facility would then award that individual, that broker, that middleman, a specific amount of money for sending that client in. Oftentimes, these brokers would also charge referral fees. So, per client that they would send in, they had a specific fee that was a nominal amount. And per client that they would send to a specific facility, they would be awarded a specific amount of money. Now, this whole chaperoning of people in and out of facilities started gaining a bit of complexity as clients were sent from facility to facility. And as this whole metamorphosis of brokering took off, it sort of evolved into this now what is seen to be kind of a human trafficking. And what I mean by that is these brokers started learning the nuances between each specific health insurance policy and their specific billing practices, their state specific nuances, and their PPO reimbursement rates. And so what they would do is they would be able to understand that if they sent an individual to a facility, say in Florida, and they maximize the amount of reimbursement for a stay, say detox, for example, they would also be privy to the information that they know that this specific policy in a different state, say California, for the next level of care would have a maximum reimbursement rate. And so you start seeing this flight pattern happening of folks being shifted from detox to then an inpatient stay from Florida to California. And then this also evolved into the tri-state area. So New York, New Jersey, Pennsylvania have become this new hotspot for individuals being sent for a step down level of care from Florida or from California, or even vice versa. So these nuances based on state-based or on state and based on insurance policy became a phenomena that we currently are kind of studying. But media has done a very good job of identifying kind of what brokering happens, how brokering happens, what key factors are involved in body brokering. But from my conversations with individuals nationally, brokers typically would admit that they have the identical role of what is now known as a marketer at this point. It's just the limelight has been shined so hard on brokering that the negative connotation and the fraudulent practices have become criminalized. And so what they've done is they've evolved from the concept of brokering to now evolving to marketing. So marketers now have this negatively or less negatively connotated construct applied to them, but it's almost the identical role. And we'll get into that in the next slide. The other phenomenon that I've noticed is that brokers typically exist in 2 degrees of separation from a facility. So you have a marketer that's either 1099 with a parent facility, and they often have communication with a broker that exists as a middleman not necessarily affiliated with a parent company or facility. And this is done intentionally as a loophole. So if a report is made for fraudulent practices, or if insurers have any inquiry with regards to a parent facility, they can then inquire and investigate on a marketer potentially. But because that marketer is 1099, no further repercussion can technically be made. That goes further out and ripples further out to these brokers that are not necessarily affiliated with the company themselves. And so that grayscaling is almost intentional. As we shift our focus to marketing, there are two realms that exist when it comes to marketing. And the ground level is identical from my conversations with marketers across the country to what brokering used to be or currently is. So brokers were renowned for going to meetings. That means AA, NA, Nar-Anon, Al-Anon, family support, grief and loss groups, and basically advertising services. And so these brokers would go to the meetings, similar to these marketers going to these meetings, and they would basically advertise that they're working loosely with a specific facility. And if they hear or know of any family members, loved ones, anyone attending these meetings that are suffering or in need of help, they'll immediately start working towards directing them towards a specific facility, being privy to the information that they're going to be getting a referral fee, a kickback, and also having awareness of their insurance to be able to continue the process and daisy chain the aforementioned material. Additionally, if we look at treatment in conjunction with or in parallel to kind of university, every 30 days, there's a graduating cohort from a treatment facility. And so these marketers or brokers kind of monitor the graduating alumni of a specific treatment facility. And as they're monitoring these alumni, they're also looking for if anyone is, in the midst of or throes of, wanting to relapse, having cravings, urges, whatever the case may be. And as soon as they catch wind of a relapse, the cycle begins again. And again, this is all information that we're kind of privy to, but again, no one's really talking about. So ground marketers have been known to be going to these meetings, and they almost act in these predatory kind of behaviors where they're advertising their services, and they're there for help. And it's this almost manipulative guise for altruistic care, where they're there in support and camaraderie, but underlying to that, there's almost this malingering that occurs where they know that they're getting the secondary gain of monetary reward. And so this monitoring of alumni, they will continue to pick them up. And, God forbid, if there is a relapse, they'll continue to try and send them out to respective facilities, again, knowing that they're going to be getting a kickback for that. Another common main stage that happens across the nation at this point is these marketers are kind of falsely providing promises to folks, kind of overselling the facility, offering amenities, a la carte services that aren't necessarily offered by the main facility or covered by insurance. And pardon me while I get a little folkloric here. I've heard of marketers promising a whole host of amenities, including food, cigarettes, Suboxone, promising that they'll be able to stay with their partner in a sober living. But this is a commonplace happening. There's a host of articles coming out from from Florida and Southern California, kind of discussing this. Kenny Chapman was a huge name coming out from Florida that participated in things of this nature as well. The other phenomenon that I've noticed is that there's also this aerial attack. And by that, I mean this cold calling phenomenon through this program called LexisNexis. And pragmatically, anyone that has known or have had this experience of getting a speeding ticket and then coming home and trying to sort out the speeding ticket madness, with or without your knowledge or with or without your consent, there's articles in the mail that are being dispatched from local attorneys, and all of these attorneys are kind of advertising their services to reduce repercussion, reduce sentencing, reduce fines, all of that. So I found out about this program very recently through a marketer called LexisNexis. And typically attorneys are using this specific program, and it works kind of like a Google filtration search engine. And basically you can adjust the filtration to search for folks that have had first-time offenses. And so what I found out is that most marketers working for these specific facilities have now acquired this program called LexisNexis and are filtering out results, basically. And so every single day they go on LexisNexis, they filter out the results to first-time drug offenses, DUIs, DWIs, nonviolent possession charges, paraphernalia charges, or anything having to do with any type of substance. And they create these cold calling sheets. And so they have these call centers that are set up, and they have a list of employees that are basically going through these lists that are generated through LexisNexis, cold calling these individuals that may or may not want help, but they're advertising their product, that being a facility. And then we go back to this entire process. So we have this cold calling, and basically through the phone, they start this referral fee, referring from a client's house directly to a specific facility. And this could be beneficial to individuals that actually need help. But again, it goes back to that idea of if not, these individuals are genuinely in need of help, and if not, these marketers are really there to help people. There's that genuine nature of trying to help someone get help. Or if it's, again, this malingering secondary gain, we're just trying to monetize people's issues. The other phenomenon that I've heard time and time again is this kind of marketing agenda of head-for-head transfers. And it got very much like human trafficking in some of the conversations I've had with marketers across the country. And folks would kind of make mention of, I'll speak to this in the next slide as well, but the head-to-head transfers and racking stack and stacking heads and beds type ideology. And all of that has to do with not skewing the revenue cycle for a specific facility. And then in addendum to that, this head-for-head transfers, marketers responsible for bringing a client in from another facility would then owe that sending facility in good faith. So it became very much this monetary exchange of clients in need of help. So as I continued to have these conversations with said marketers, I couldn't help but think of films and books like Wolf of Wall Street, specifically as they started talking about their salaries. And so in the film, we had Leonardo DiCaprio kind of advertising this specific product, and everyone was kind of jumping on the bandwagon with regards to how they could generate a lot of money. And so this is where that kind of parallel came for me, or something that came up for me. So when I spoke to specific marketers, they admitted that they were given a specific base salary, and there was this commission structure that was kind of arranged by the operators of the facility. And so if an individual marketer was able to bring in X amount of clients per month or X amount of admissions per month, they were giving an additional commission or an additional monetary reward. And further in conversations, marketers would admit that, there was an individual quota that incentivized, continuing the cycle of getting individuals in. And there were team goals for the entire team of marketing. And this commission structure plus base salary plus commission for X amount of admissions per month individually, plus an additional commission structure for X amount of admissions per month for a team goal, very much made me feel like this is just a monetary gain. And again, this is my inherent bias. And so we have this like externalization and sort of extrapolation of what was essentially body brokering happening at a ground level in this grayscale to a doctored construct to make it sound more legal, but it's happening on a wider scale because the epidemic is taking off the way it is. And I mentioned these points before, but these marketers repeatedly had this incentive or constructs of heads being part of it. And the other phenomenon that I've noticed is across the nation in very different parts of our country, marketers repeatedly would say that at the end of the day, this is still a business. And when I heard that, it just struck me like the Sacklers, big pharma, pushing this agenda of just trying to make as much money as they possibly could. And if you talk to a specific marketer about their treatment facility, they all say kind of the same broad strokes. It's individualized care, offering CBT, motivational interviewing, a list of a la carte services, along with medication-assisted treatment. And so if you look at treatment as a whole, we're not really offering anything vastly different. It seems as though we're kind of mirroring the paradigm that Big Pharma, specifically the opioids that were produced by Purdue Pharma. And it almost seems as though the way in which Big Pharma pushed these analogs of the same product, treatment is following that same bad blueprint with regards to pushing analogs of the same treatment model, none of which is efficacious really. And if you look at kind of treatment, it hasn't really changed from 1955, which is also something food for thought, essentially. So that is my synopsis of brokering versus marketing. And I'm sorry again for it being kind of all over the place, but there's no clean way to kind of talk about it, as I mentioned before. So here and now, I'd like to kind of go into the interplay of open enrollment and the levels of deception. And I wanted to talk a little bit more with regards to the impacts of open enrollment on substance use disorder treatment. This specifically pertains to the Florida model of care, but I'm noticing that this phenomenon is also rippling out to all levels of care, meaning inpatient and even in the nonprofit sector. So the interplay. Knowing, as I first mentioned when I started this conversation, that most folks don't have out-of-network benefits to meet the for-profit facilities' need, most folks will have Medicaid or Medicare. So the first thing that's seen time and time again is this phenomenon of scholarshiping. And I've seen this happen in the Florida model of care. I've seen this in the for-profit sector generally. I've also seen this in the nonprofit sector. And so this scholarshiping is pretty much awarded so that an individual is guaranteed 14 days in treatment, and that's cost-free on paper. Hold that thought. So on the 15th of every month, folks could then apply for a specific PPO commercial policy, for example, and that is something that we need to look at. So before I say anything more, we all know that posing as an insurance broker or enticing someone is completely illegal. That's fraudulent behavior. So if a marketer is able to encourage a client and their families to purchase a specific commercial PPO plan, then that said individual that is in need of care would be able to access the for-profit facility. So again, marketers posing as insurance brokers is completely illegal, but time and time again, as I've had conversations with marketers across the country, they would preface a conversation stating that they are not an insurance broker, but if they wanted to get their family member or loved one the care that they need through this facility, then they would need to opt into this specific for-profit commercial PPO policy. And this is where I want to kind of harp for a moment. So these marketers know they're privy to the information that this specific commercial PPO policy is going to yield the highest reimbursement for specific levels of care for the receiving facility. These marketers also are aware that they're able to charge the receiving facility a referral fee, and these marketers are aware that they'll be able to get a kickback, which could be an addendum to that referral fee. So there's a lot of manipulation happening here. And again, it's all under the altruistic guise of let's get these clients, the clients care that they need. All the while, they also know, these marketers, that their for-profit facility that they're sending the client to may not necessarily be efficacious, if at all. And so again, this altruistic manipulation of parents looking to save their kid or whoever else is suffering from addiction, it kind of goes under this guise of social welfare. This gets even more convoluted. So if you look at a specific commercial PPO plan that would typically be accepted from a for-profit facility, especially an out-of-network one, commercial PPO policies typically cost in the ballpark of $350 to $400 per month. That's a lot of money per month. But if you look at the reimbursement rates at each level of care for a for-profit out-of-network facility, detox sometimes gets upcharged to $5,000 per day. Per day. I just want to enunciate that. Inpatient gets upcharged to $3,500 per day. PHP often gets upcharged to $2,500 per day. And IOP gets upcharged to $1,800 per day. An outpatient has no finite limit to the amount of sessions that are awarded for a for-profit facility. Now, these numbers are coming from directly from a facility I used to work at. So I'm not trying to conjure this information up. I can definitely prove this. And in addendum to that, if you look at an in-network facility, the reason why most individuals opt in to go to an in-network facility is because the overhead is minimized. If an individual is going to an out-of-network facility, they're opting out of an in-network. Therefore, that out-of-network facility can upcharge their services that may be identical to an in-network facility. And oftentimes insurance will have to pay whatever the out-of-network facility is charging. But whatever is offset, the difference, sometimes gets billed to the client. And so for a specific example, if a max rate for an in-network facility for, say, a detox level of care is $1,000 per day, an out-of-network facility can offer the exact same services as that in-network facility, but then charge $5,000 per day for that same stay or that same interval. And again, insurance sometimes has no other option but to pay that $5,000 per day, the quoted rate for that out-of-network facility. But that offset, that $4,000 difference, sometimes will get billed to the client. And more often than not, the client is not aware of that. And so the client then receives this lump sum bill for their entire stay that can be in the ballpark anywhere between, I've seen from $50,000 all the way up to $300,000. And so time and time again, the clients will then call and ask, what am I supposed to do with this bill? And so I've been in situations and I've spoken to a number of clients across the country where they are told by the insurer when they call their insurance company to, figure out what to do when claims comes for collections. Insurers often will say that it's the onus falls on the client to be able to pay the lump sum that's due. If the client then calls the billing company for the facility that they attended for care for, the billing company then says, don't worry about that bill, tear it up. There's no reason to fret over it, pretty much. And so I continued investigating this. And what I found was that the fiscal calendar year of the facility, at the end of the fiscal calendar year, when the facility has to go to pay their taxes, whatever is left unpaid, including this $4,000 per day differential, meaning if the client doesn't pay, that means that gets written off at the end of the fiscal calendar year as charity care or unpaid care. And so that becomes a tax deduction for the facility. And so if you look at this from a macroscopic lens, you have this hemorrhaging of funds from the insurance company going to this out-of-network for-profit facility. And the for-profit facility can then write off whatever goes unpaid. So you have this obscure money exchange happening. And this is where the treatment industry is kind of going. So I wanted to look a little bit more in depth with regards to scholarshiping and what's really happening here. And so this, again, is coming from firsthand experience, and I've seen this time and time again. So right away, when an individual is scholarshiped, they're admitted, and the chief operating officers, the CEOs of the company, the billing team kind of lets the entire clinical team know that whatever happens with this specific scholarshiped individual needs to be documented from day one, no matter what. That means all individual sessions, all family sessions, all case consultations, all case management, all family contacts, you name it, all psych appointments, everything gets billed and documented from day one. And so what happens from day 1 to day 14, however which way that the client is able to acquire a private commercial PPO policy, day 1 to day 14 is pretty much documented at the facility. Day 15, when that PPO policy is active, whatever was done between day 1 and day 14 is then back billed to that commercial policy. And oftentimes that insurer will lump sum back bill and back pay, essentially, the receiving facility. And so facilities tend to do this often because they are awarded this lump sum reimbursement that is pretty gargantuan. If you think about the amount of money that they would be able to make for, a detox stay or an inpatient stay or PHP level care stay, they're able to acquire a large amount of money for that. So there's a lot of incentive to be able to backdate the day 1 to day 14. Thereafter, from day 15 through completion of the program, the billing cycle continues as per the facility, normal regiment billing cycle. And so again, this gets a little bit more complex. So when we look at treatment as opposed to incarceration, soapbox moment here for a second. Treatment as opposed to incarceration would have been a beautiful idea back in the 80s during the crack epidemic, when Black and brown folks were just thrown into prison cells recklessly, honestly. Treatment as opposed to incarceration should have been offered then. Here and now, as the epidemic has kind of rippled out into white suburbia, it's almost a dignity thing that the courts are now throwing this on the table, that it should be awarded, and it should be a talking point. And so, because the courts are now seeing more Caucasian people being incarcerated or coming into the courts on possession charge or paraphernalia charges, it's kind of interesting in a very negative way that treatment as opposed to incarceration is now a colloquial term being offered. Sorry for my soapbox moment. Anyway, so treatment as opposed to incarceration is this new phenomenon that I've seen time and time again. And if someone is coming in from the jail cell or from prison, for example, oftentimes those individuals are unemployed. They don't really have family members or loved ones to be able to fund for a commercial PPO policy to ensure care for an individual for a specific for-profit center. This I'm also seeing happening in the nonprofit sector at all levels of care. And I can prove this again, this will come out in the dissertation. But what I've also seen is that the for-profit prison system, I've had conversations with a few folks at the for-profit prison system, specifically in Texas, and they have made mention that they are able to accrue $350 per inmate per day, just in the incarceration system, in the for-profit incarceration system. In the for-profit system, they also offer treatment as medication-assisted treatment. And so they are privy through their lobbyists and through for-profit treatment to the information that for-profit treatment is able to accrue a large amount of money, more so than that $350 per day per inmate that they're accruing in the for-profit prison system. And so this is something that we need to have a conversation about, because this is, again, is information that folks are already talking about. This is information that we're already privy to. But it is also interesting to look at as folks in the for-profit sector are now talking to lobbyists who are talking to congressional folks to make this bill a thing, where treatment as opposed to incarceration is a phenomenon. And if you look at the system of the for-profit treatment center, the for-profit treatment center, what I've found, create and manifest these nonprofit LLCs. And these are pseudo nonprofits, and they exist solely as another loophole. And so these for-profit centers create these nonprofit LLCs that act as subsidiaries to a parent company. They name these these nonprofit LLCs anything they want. And money is taken from the for-profit center and siphoned out into this nonprofit LLC. And so the money that goes into this nonprofit LLC is then used as another loophole to purchase these premiums, these commercial premiums, the $350 to $400 premiums for private PPO commercial policy during an open enrollment on the 15th of every month for those folks that are in prison, for those folks that are in jail, that are in need of care, as opposed to incarceration. So again, this would have been a fruitful idea back in the 80s. However, to me, transparency, here's my bias again, it seems like it's just legalized money laundering. So just as the aforementioned, the intentionally purchased PPO policies still have the highest reimbursement for each level of care. And so this for-profit center then is pretty much double dipping, purchasing a commercial PPO policy and then using that purchased PPO policy to then get the highest reimbursement or highest yield. And if you think about the cost benefit analysis here, a for-profit center that's shifting out $350 to $400 for a month is able to bill that specific policy $5,000 per day for detox care that they're receiving or providing that individual at their specific facility. The cost benefit analysis is exponential. And that's the reason why some of these for-profit centers are able to generate $42 million in a year or $60 million year two. So that is a short synopsis, as easy as I can make it. Interplay between open enrollment, the levels of deception, and kind of the interplay between the two. This further gets convoluted, and I wanted to include these points because these are current happenings. I feel like marketing and brokering are things that we're all kind of aware of. But I did think it was important to sort of talk about these next convoluted practices a bit. So when it comes to intake folks, what I found to exist in with regards to standalone detoxes, for example, they're loosely affiliated with these facilities, these for-profit facilities specifically. So back in the day, a hospital system would have their own detox, and if someone came into their detox, they would often be stepped down to their inpatient within the hospital system. Now, what's happening here and now is these standalone detoxes are, instead of sending to a hospital system, for example, they're sending them to these for-profit facilities in the area. Now, again, everyone is fully aware that enticement is illegal, but there are loopholes that are being followed to avoid anything illegal. And this is strategically done so that folks can exist in these illegal loopholes, but not face any repercussion. And again, this is parallel to big pharma and kind of emulating exactly what the Sackler industry did and Purdue Pharma did with their relationships with these physicians. Insys and John Kapoor, for example, comes up in my mind with regards to directly blackmailing and manipulating doctors to be able to prescribe and write this specific script for their product, essentially. But what I've noted and what I've kind of had conversations and am able to prove is that there's these non-traceable arrangements, and whether that's done in gift card arrangement, pens, luncheons, cash pay for referrals, these intake folks at these standalone detoxes are often awarded another version of these kickbacks or referral fees. I've had conversations with individuals in the tri-state area where counselors at these standalone detoxes were awarded $500 per client that was referred over to a receiving facility, meaning that facility, the receiving facility, would physically drive to that intake counselor's home and award them $500 in cash or give them a gift card. Some sort of transaction was made. And so what happens is that these detoxes then become heavily linked to these specific receiving facilities. And each counselor at a detox then becomes affiliated with a specific facility. And there's this, again, manipulation and this weird malingering that occurs where coercion is happening. And so that detox that is the counselor that's working at a specific detox is then marketing that specific receiving facility, all the while being privy to the information that they know that they're going to be getting this cash reward for sending this client over. And so it, again, mirrors the marketing practices, which again is extrapolated from body brokering. So it's the exact same paradigm, it's the exact same parallel. And so when you talk about clients receiving this specific referral to go to this specific facility, I've spoken to specific clients from this said counselor in the tri-state area. And the client said directly that their counselor pushed this agenda on them, their families, to be able to go to this receiving facility. So again, this malingering is happening. And again, I apologize for being folkloric, but this is absolutely happening. The other phenomenon, and this is also very convoluted, this goes back to that point that I made with regards to every 30 days, again, in parallel to academia, for example, every 30 days in a treatment facility, a new cohort is basically graduating. So that means that every 30 days, these newly graduated cohorts, some of them are actively selected to be employed by the same facility that they just completed treatment in. I've experienced this. I'm sure everyone can attest to experiencing this. Day 31, you see a former client then being employed. They're given, full salary and benefits. And, I'm prefacing this with, I fully believe in extending handouts and awarding people that truly deserve it. And, giving individuals an opportunity to move on this trajectory to reshape their entire life, I'm all for. However, I do want to preface that with, we need to be mindful of the amount of money that these individuals can acquire early on in recovery, because that is where the hiccups kind of happen. And so, like, I firsthand have worked in some facilities where day 31 former clients were hired. And, I think that's intentional. I think there's value in that, but it also creates buy-in for the current clients that are in the next generation cohort, to witness that, a client that just recently graduated the program is now being employed by the facility. I think that's a beautiful thing, idealistically, but pragmatically, there's a host of options and issues that come up. So as these newly hired clients come in, they start engaging in the marketing practices, kind of the brokering practices. They get involved in the call centers that we spoke about earlier on. They also get involved in like alumni monitoring. And every graduating cohort, they're sort of continuously in contact with these folks that have graduated the program. And God forbid, if there is a relapse, they sort of help the process along. And so, from a clinical standpoint, time and time again, from both the nonprofit and for profit sector, I can attest myself to seeing treatment as this revolving door. But if you look more macroscopically, it kind of seems like it is intentionally a revolving door almost. Um, and when these newly hired clients start bringing in future clients, essentially, um, this phenomenon of paying clients to be in treatment for a specific amount of time becomes this routine. And so, I can attest, as well as being in a biopsychosocial assessment and asking a specific client, why are you here? Some of these clients are very transparent with regards to, being paid to be there in treatment. And the reason that I can only hypothesize would be that, these newly hired individuals are trying to get their quotas in for that specific month. So if you go back to what I mentioned with regards to marketing practices and the commission structure and being awarded an additional incentive for your individual goal. So if a specific newly hired client, a new employee, was attaining that specific quota, they're also incentivizing these new clients to be there with a cash pay as well. And so the cycle then manifests again. And there's this other paradigm of that, where, clients would admit to being paid $2,700 to be in treatment for a 10 to 14-day stay, with, again, the amenities offered through their marketers or their, whoever got them in there for treatment, of, Suboxone, cigarettes, and, being able to cohabitate with their partners. So I know that was a lot of information, and I'm fully aware that my bias definitely radiated through the entire time. But what do we do? So as a clinician myself, I've worked, as I mentioned, nonprofit, for profit. The only thing I can say, as fitting as it may be, as a bearded brown person, if you see something, say something. I currently do consultation with a lot of clinicians from across the country. They often have this conversation with me about how they're seeing things happening repeatedly at the facility that they work within. And oftentimes they're apprehensive to come forth and speak about it, as they don't want the attention, they don't want to spark any trouble. They don't know what's going to happen to them as far as legal ramifications. They don't want to be labeled a whistleblower. And the bottom line is, they don't want to be listed as like a troublemaker. At the end of the day, they're there for their clients. They want to help their clients. And they feel as though if they stood up and said something, that's going to jeopardize their client care. Fully agree with that. I can absolutely empathize with that. But with that said, just as I say to them, I'll say it here now. If we ourselves are not standing up, and if we choose not to speak up, then I fully believe that we are participants of the carcinogenesis of this problematic treatment episode that we're currently in. And in my mind, we're past Malcolm Gladwell's tipping point. We are in the throes of kind of this upward trajectory of new line treatment. that again is just an analog of something that just doesn't work. And we can't keep continuously providing this one set catch-all umbrella of treatment that's non-efficacious just because there's no better option. I've spoken to congressional folks about this, and I know I'm not the only one. There's plenty of other folks that are well esteemed that are saying the same exact thing. But I truly, genuinely mean that the onus falls upon us, and this is the gap in our care and in offering quality care. And so we need to sort of get rid of the bad apples, if you will, because right now there's accrediting bodies that are running around recklessly accrediting these said for-profit organizations that are doing the exact same thing that I just mentioned throughout this entire PowerPoint. So when it comes to actions, what do we do? So something that worked for me that I'll share with you all is speak to your supervisor. Always speak to your supervisor with regards to your concerns. Contact an external mentor if you need to. Speak about your concerns openly, and always know that your supervisor is there to help you so that you can have a sounding board as to which direction you need to go in, if you need to go in a direction at all. I would also strongly recommend speaking with a lawyer in your area about your concerns. I personally feel as though a PhD JD is the ultimate combination, meaning a PhD psychologist or a PhD, counselor education supervision, PhD, anyone that is a PhD JD in your field, that is an ideal person to walk with because they will navigate both sides of the spectrum, if you will. I would also recommend speaking out to the ACA ethics boards. Speak to the NBCC, they have an ethics board as well. And also contact your malpractice insurance. They offer free legal consults, and allow them to know that you're very concerned about, whatever it is that you're seeing, or if you should be concerned at all. And with that said, also, when it comes to speaking to your lawyer or when it comes to speaking to your mentors or any type of law body, follow the directives of your lawyer with regards to your state specific nuances. Every state is completely different, so just be mindful of that as well. So my final remarks. So what I've seen in my study, and again, I've been looking at this for the past 4 to 5 years, all I can say is that this current paradigm that we're existing in, kind of witnessing in, is a profit-driven, profit over people, which is at an all-time high. We've seen that with the Sackler industry. We've seen that with Purdue. They're filing for bankruptcy to evade having to pay back money. And it seems as though the only thing that wins at this point is having a large bank account. And that's what's most important to folks at the top. And in my personal opinion, I feel like we've gone from a place of enslaving people to crop product off of, to profit off of, to now we're cropping people to profit off of. And you see this time and time again with for-profit prisons. We're now seeing this happen with for-profit treatment. And I genuinely believe that treatment as opposed to incarceration is a beautiful idea, idealistically. But with lobbyists and congressional folks and being privy to specific loopholes, it just seems like it's a continuation of the same bad blueprint at this point, which I would offer for you to consider this point. Think about where you're working, think about what you're experiencing, and consider what it is that we're really engaging with, and vouch for your clients, because we are in a time of social justice is paramount. And the rich are getting richer, and it seems like we're getting trapped in this cycle. So please consider that. My final point, this is a list of validating articles that kind of review everything that I've mentioned. Things are happening, specifically in the tri-state area, bleeding and hemorrhaging out into Southern California and Florida, and it's rippling out even further into places like Ohio, Arizona, Minnesota, and even Texas for that matter. And it seems as though this phenomenon is hemorrhaging out across our country at this point, which again goes back to my point of past the point of Malcolm Gladwell and the carcinogenesis of what we deem to be treatment. So that is just food for thought. Again, my name is Kapil Nayar. This is my presentation, and I just want to thank NBCC again for this opportunity. I'm extremely grateful that I'm able to present on this topic. Again, it's near and dear to my heart, and this is something I'm going to continue studying for my dissertation. So thank you much for all of your time and consideration. I hope this was helpful. I apologize in advance if it was super biased, but this is where we are. Thank you again, and feel free to reach out if you have any questions, comments, concerns. I'm happy to answer anything. Thank you so much.